Top Med Talk.
Welcome along to Top Med Talk. This is part 2 of a 3-part series on perioperative anaemia. Some listeners may recognise this as one of the key moments during EBPOM London. It's co-chaired by Mike Grocott, Professor of Anaesthesia and Critical Care at the University of Southampton, and Rachel Barlow, National Lead, the Enhanced Recovery, Prehabilitation and Optimisation Service at Cardiff and Vale Health Board, Wales. On the panel, and facing audience questions, we have Scarlett McNally. You may recall her from part 1, where she gave a short presentation. She's the Deputy Director for CPOC and Honorary Clinical Professor at Brighton and Sussex Medical School and Consultant Orthopaedic Surgeon in East Sussex. We join the conversation as Mike Grocott welcomes another panel member onto the stage, and audience questions begin. Have a listen.
So I'm going to ask our 4th panel member to come up, Jamie Plum, who's a consultant colleague in Southampton, consultant anaesthetist and perioperative physician, just finishing, 5 is on the horizon, so sorry to stress you, his PhD, which is all about anaemia in the perioperative setting. Well, I think he's going to help us with some comments on some of the studies. So Scarlett, Centre for Perioperative Care, which we're both involved with, multidisciplinary, multi-specialty, very pathway focused, and the guidance, and I wasn't involved with this one at all, I've been involved in some of the previous guidance, but my take on the strengths of it is it is multi-specialty. It's evidence-based, so there's a proper systematic review process behind it all, and that is sieved through the shared wisdom of multiple stakeholders from the various partners. IV iron. I'm going to ask Jamie to just give us a quick praise. You touched upon the PREVENT study. So I think you made the right decision. We all think IV iron works, but the study appears to say it doesn't. I'm going to ask Jamie to outline what the study said and then come back to how it squeezed in. So Jamie, tell us about PREVENT.
Sure. So PREVENT was a large multi-centre randomised parallel group controlled trial looking at Ferinject versus placebo, and it ran over 5 years, predominantly UK-based study. There were loads of good things about PREVENT. The protocol was very well followed, the loss to follow-up was very, very small, and it was a pragmatic trial. There were some downsides, but the bottom line of PREVENT was that they showed no difference with the co-primary outcome. So the reduction in blood transfusion or mortality was exactly the same in the 2 groups, which I'm sure was a great surprise and disappointment to the people who are involved in running that trial. Many of us in the room, certainly myself, probably recruited patients to the PREVENT study. But the study has been sort of drilled into, I certainly have in public forum before, for some of the downsides of the study, which are worth talking about and considering at some length, really.
What were the discussions in the room like? Because it's always a bit challenging when most people believe A and the study appears to say B.
It was very interesting. As I said, people were expecting the PREVENT study before it came out. There was quite a lot of hype, I think, because so many centres were involved in recruiting, but it didn't say what was expected. The difficult bit for us is you actually don't want just somebody's got this level of anemia, put them on the IV iron, they'll be fine, because what we're trying to do is to make people better for the rest of their lives, if you see what I mean. And some people have incredible nutritional deficiencies without realising it. And some of those can be improved very efficiently by the patient themselves, just with some leaflet, or by the patient and their family. It's not wait 16 weeks until the dietitian is available, for example. You can improve people's diets. It's often diets or it's blood loss they didn't realise they were having. There's often things that can be improved, and you don't really want just the reflex give IV iron. And the other thing is around oral iron. The international consensus statement from Munoz et al. Was very clear about alternate day oral iron, because otherwise, if you take the ferrous sulfate 200 milligrams 3 times a day, as the BNF tells you to, you stop absorbing it and you have horrible constipation and diarrhea, or one or the other, or both. But so people don't take it. So there are better ways of taking oral iron. You can take 1 tablet every other day. It's probably just as efficient, or equivalent dose for children. So in a way, because IV iron isn't perfect, anaphylaxis or whatever isn't a problem nowadays. It was, many years ago. So, and you can get a system going, but actually what you need is to consider the patient in front of you. So it's not just a reflex, but we probably need better IV iron services around the country, but it shouldn't just be the only thing people think of, if you see what I mean.
Yeah, absolutely. It's part of the pathway. And I guess the other element I didn't emphasise with the CPOC guidelines is if they tend to pool the input of a variety of different guidelines that are relevant to different stages of the pathway and bring them all together. So there often isn't a need to do primary evidence synthesis because it's been done by a specialist society elsewhere.
Yeah. Although we did look at huge numbers of papers. Luckily, I was shielding during the pandemic, so I just sat there on my kitchen table with all of these. And everybody else did. It wasn't just me, but pulling together on my kitchen table. We've gone through all of the, different. We have people picking out different papers to analyse and so forth. So it's got the evidence behind it, but as you said, it's pulling together the other guidance, and some of it is the clashing between Munoz', I think it was 2017, and the World Health Organization definition of anemia, for example. I think
that's really important. So just for anyone who doesn't know, in 1967, a few people sat in a room and went, where should we put the level? And the reason they did that was very unscientific and was purely a matter of if they'd said 130, everyone would have been anemic. But the reality, and we have to, I'm a strong believer that we should be treating both women and men at 130. And that's what we do in our centre now, on the basis that proportionately women lose more blood, because they have a smaller circulating body mass and therefore a smaller blood volume. So blood losses in a woman are more significant, yet we tolerate lower levels of hemoglobin. But I think fundamentally and possibly more important than any of that is that so many women, just in this room right now, there will be non-anemic iron deficient women, 100%. And it's utterly life-changing when these women receive intravenous iron. I know this because consultant colleagues have phoned me up 6 weeks later and said, "You have literally changed my life." And that will be the case with patients, because GPs don't necessarily do anything about it. HB comes back at 125, 124, so what? But they've been living with this low level of ferritin for their whole life. And that's really gives you loads of really bad symptoms. Anyone who's had a low ferritin will testify to that. And I think we're massively missing a trick. What we don't have is any big perioperative studies that have looked at non-anemic iron deficiency. We've got loads of studies in the sports medicine literature that support the fact that potentially has detrimental effects on outcome, or certainly on performance if you look at the sports world. But we don't have that because no one's looked at it yet. There's a very, very small trial, and Toby, who did the PREVENT trials, looked at that in some athletes at St Mary's, actually. But yeah, so there's a whole massive raft of stuff that still needs to be done in this sphere, and that's just one small part of the story. So we would treat people with low ferritins and normal hemoglobins. It's sometimes a little bit of a toss-up, and it's patient by patient, but I think there's certainly mileage in doing that, despite there being no actual evidence to support it.
Why is it the right decision to kind of ignore the PREVENT results?
So I think,
and is there a harm signal?
Yes, I think it's dangerous to say you would ignore the PREVENT study, and I know you don't seriously mean that. It was a very well-conducted randomised controlled trial. We have to consider it very carefully. There were some major drawbacks with PREVENT. 76% of the patients in that study didn't have iron deficiency. That's a massive headline that we have to digest that. 25% of them came from one centre. That may or may not be relevant. But what certainly is relevant is that iron deficiency wasn't a prerequisite for being in that study. So it was just all comers with anemia. It was only open surgery, and actually in most westernized medical systems, open surgery is certainly diminishing. In our centre, it's rare to have open surgery. How relevant really was that at the time when the question was asked? Predominantly, we were doing open surgery. With laparoscopic surgery, you bleed less. The transfusion levels were much lower than it was powered for. So they were powered for a 40% transfusion rate, and they only got about 24, 25 from memory. So you could argue that it was underpowered. They slightly under-recruited. These are sort of small things, but one of the fundamental problems, and I think probably the headline issue with PREVENT, was that if you do a pragmatic study with the outcome being blood transfusion, but there's no sort of criteria set for when you could give blood. So as you all know, if you work in a tertiary hospital, the decision to give blood isn't always consultant-led. It might be led by an FY1 at 3 a.m. when a nurse hands them a blood gas with a hemoglobin of 60 or 70. And actually the decision-making process about who gets blood wasn't defined in that study. So anyone could give blood. And if the surgery was technically difficult, or the tumour was locked to a whole series of blood vessels in the pelvis, then of course they were going to bleed, and they may have needed blood. But it had nothing to do with the fact that their anemia or their nutritional deficiency led to their worse outcome. It was to do with the physical surgery. So there were big problems, but not being anemic was a big one. And then not defining who got a transfusion was another one.
Ignoring is completely wrong. I mean, Toby Richards did a great study. Studies are challenging.
Absolutely.
But we did ignore it in Southampton. So why was that?
So I think, like anything that we do in medicine, we often have our own biases, whether they're right or wrong. I think there are signals in other data that there's good outcome from treating anemia. Certainly all of the observational data, time and time again, has shown worse outcome, and that's unarguable now. But we do have some really interesting data from Austin Atchison Group in Nottingham, who did the Evica trial. They also, in their original paper, didn't show any difference in blood transfusion, but then they reanalyzed it, I think, a couple of years ago, and they did show a quality of life improvement. And I think, actually, again, we have to think about our primary outcomes in studies. What are we trying to measure? So patients don't care. They care about living or dying. That's true. But they don't necessarily care about how many days they're in hospital so much. But they do care about whether they can walk the dog, and do they get breathless when they're doing that? Can they do the activities that they enjoy? Can they go to the pub with their friends? And if you're really, really anemic and really iron deficient, it's a struggle to do that stuff. So if 6 weeks, 8 weeks, 9 weeks down the line, your EQ5D score is much higher because your anemia has been adequately treated, happy days. You're a happy patient in a much better place. And I think actually when they looked at that, they found that the quality of life was better. And I think any study now that looks at treating anemia has to include quality of life metrics as outcome measures to be useful.
And in practice, we did see a reduction in transfusion when we started.
We did in our centre. So in a non-randomised, prospective, quality improvement initiative that we've then rolled out and continued, we did see a huge reduction in transfusion. But again, it's really difficult to say that, cause and effect with that outside of a randomised trial.
Rachel.
On the back of clearly what you're saying, there's a question, what IV iron dose should we be using? 20 milligrams per kilo?
That's a solid starting point, I would say. We certainly would look to do that. I mean, you can use the Ganzoni formula if you want to.
Yeah.
I mean, if a patient's under 50 kilos, then probably it's better to use the Ganzoni formula. But I think 20 per kilo, and product is irrelevant. We've used both products. We happen to use a certain product in Southampton. Just for logistical reasons, you can give one of them slightly quicker than the other one. I've been given money from both of them, so I have no preference with which one we should use. But 20.
Can we be clear? You've been given money to conduct studies.
Correct. Yeah, correct. 20 per kilo is a solid starting.
Okay,
point,
I think we'll ask Scarlett about the top one. My expert orthopaedic surgeon tells me he never loses 500 mils of blood. Should we aggressively be treating preoperative anemia before arthroplasty?
Arthroplasty is quite a big deal. As Jamie said, you want to be able to get out and do stuff, climb stairs, all that stuff. You want to be able to get up, use your crutches, use your new hip or knee or whatever. It's not just about how much the surgeon thinks they're losing. You've also got continuing bleeding into the tissues. It's not necessarily what's lost at the time of surgery. I had a hip replacement last year, actually. I had my steak twice a week beforehand and all that stuff, and cycling, electric bike. My hemoglobin went down to 90 afterwards. Just actually, even with, obviously it was the most meticulous person you can imagine because I can choose my surgeon. But, it just, and how does that surgeon know? Because we don't actually measure it.
I think it goes back to your point around quality of life as well, doesn't it? It's not just about the process of the operation. It's about long-term quality of life. So question here about primary and secondary care. Where does the line sit between primary and secondary care with regards to investigation of the cause of anemia for patients with incidental findings having minor ops?
You could probably answer that yourself because you've got expertise in the primary secondary care interface.
I was going to just share some of what we're doing around primary care, secondary care interface. But before I do that, do you want to just take that, or Mike, one of you?
I can take it if you want.
Yeah.
I mean, we tackled this in Southampton, so it's a really good question because this is what happens in real life. Hemoglobin's 90, they're having an operation on their finger, you haven't got time to optimise them, what do you do? So we just have a standard pro forma of what happens in that situation. So we have an anemia specialist nurse, there's a standard template letter that goes out to the GP. I think if they're really low, then they get a phone call and it's sort of aggressively chased. If they're sort of 110 and actually they're in and out for a day case, there's just a letter that goes. Patient gets told and informed, obviously, and is often then started on treatment. But you have to make the diagnosis, as was said. That's absolutely critical. Are they B12 deficient? So 15% of people who are iron deficient will also be B12 and folate deficient. So it's important that you look for all of them to make a diagnosis. And some of these people need to be top and tailed. Absolutely. So we directly refer those. So if they're symptomatic and they have obvious GI symptoms, then we will directly refer to our gastroenterologist in-house. I know that the CCGs and the way the money flows historically it was very difficult and challenging to do that. That seems to have become, maybe because of COVID, I don't know, but it seems to be slightly easier in our trust. So we can go direct to a colleague for things like that. But yeah, predominantly it's back to primary care.
So picking up, so the question you said about referring, so you'd refer to the gastroenterologist, but you'd also notify the GP?
Yeah, if it was
a treatment plan? Or?
If they had a clear history of worrying GI symptoms or urinary symptoms or gynae symptoms, we would make a referral. Yeah. And if not, it would go back to primary care with a standard pro forma letter.
But bearing in mind, our guidance covers the 4 UK nations and there are different political setups. So we also got some standard letters for GPs. We're recommending that somebody takes it on, and it will be different in different places, but kind of all bases covered. What I found quite interesting reading the British Society of Gastroenterology guidelines is that they welcome referrals. Because, often you think, I better do as much as I can myself. Should we get a CT? But it's like, no, refer to them and they'll probably get a gastroscopy and a colonoscopy if the patient needs it. But bear in mind, some very elderly people, you might want to balance whether you're doing that or depending on the size of the operation they're having. So, but you kind of need to cover the political situation that you're in and maybe advocate for better political systems.
Lovely.
But
Thank you.
Got time for that bit.
Whilst we've got you, Scarlett, as well, what does CPOC conclude regarding EPO use for preoperative anemia?
So EPO is
Sorry to put you on the spot.
That's erythropoietin, and there are specific indications for that, particularly off the top of my head, it's renal patients that are particularly valuable in. There are some, say, Jehovah's Witnesses, or if there's another particular reason that you might be doing that rather than treating the iron or the B12 or the folate, you might have a better answer.
We use it, we use it in the context. So the big group in our hospital would be the intestinal failure group. Yeah. So we have a quaternary referral service really for those patients. They often come with a known inflammatory chronic septic type condition. They bumble along with a CRP around 10 to 15. They do not respond to intravenous iron. So often they are the classic functional iron deficiency group. So we will treat them with EPO from time to time. There's this whole historical tension with erythropoietin and cancer. And there's this concern about VTE. That's not really a thing. In my reading of the literature, that's just not really a thing. You have to tease those studies out. So a lot of the stuff in the renal, this is just standard fodder for renal patients. All of them are on erythropoietin. I think it's probably underused in the perioperative setting, but we don't have the trials to support that. There's some data in the cardiac surgical group where they've mixed intravenous iron, erythropoietin. Actually, they've thrown the whole bus at it. They gave B12, folate, everything in one of the recent cardiac papers and showed a reduction in blood transfusion on bypass. So there's something in it for sure. We use it, but very selected. It's expensive.
When you say we do it, we've had a long conversation with our haematologist.
Correct.
That to work out the sort of constraints on when we do it, when we don't do it, when we refer it.
Exactly. But it's case by case. So you might get one who might be suitable and actually we end up not giving it to them. But it is very expensive.
Yes, the audience. Big one.
Yeah. So this is an observation really from being someone who's followed this story for a little while from the perioperative setting and has had various relatives prescribed by GPs, and thinking back to my own medical school days, which were getting further away, but weren't all that long ago. And we were very much exactly as you described. And if I look in the BNF now, it talks about oral iron 3 times a day. Where are we on shifting that conversation, given that in the perioperative space, we seem to have pretty much accepted that is not the most effective way to administer iron. But time and time again, it's what my relatives get offered. It's what I learned at medical school. And it's what the FY1 on the ward would probably prescribe.
CPOC is now one of our actions from our last meeting is to write to the BNF and say, why have you still got this when Minos et al. And everybody is saying don't take iron that often because it doesn't work. Every other day is better. And the other issue is around post-operatively, oral iron doesn't work so well because you've got an inflammatory thing going on. So again, it should probably be alternate days. And again, there isn't enough evidence around post-op IV iron yet, but there is a place for it in some people. But so we're going to try and change the BNF.
Brilliant. Thank you.
But that's a pretty important take-home from this discussion.
Yeah. I think a lot of credit has to go to Toby and to Manny Munoz for that as well, because they've been banging on about this for years and years. So that's definitely something that needs to happen.
As a dietitian, I did see to put in there about the bioavailability of oral iron absorption, and certain preparations are better absorbed than others. So one size does certainly not fit all. And the bioavailability of the iron preparations that we take orally can be maximised, and I'm sure everyone knows this, by vitamin C. So again, most people will take their iron tablets with a cup of tea. That's the worst thing because the tannins of the tea bind with the iron. So, so I think some of the GI symptoms that people get with oral iron are a result of the malabsorption of the iron as well. So it's not as simplistic, and obviously that's why red meat, the bioavailability of red meat iron absorption is much, much higher than you would get from a vegetarian diet or from an oral iron preparation. So I think it's not as straightforward as oral iron is not just oral iron. It's to do with the bioavailability and the compounding.
Probably best to avoid the red wine with your red meat because of the tannins.
Yeah, well, it's a different way. Red meat is absorbed in a completely different process. So, okay. Any other questions from the...
Just really follow up from that last one, really. In the ITU patients, we have a lot of them are iron deficient. What do the panel think about IV iron in that group of people? They're not all surgical, obviously.
So a great question. People are still really unsure about it. There's this historical piece about what happens to bacteria in a Petri dish if you give them iron. They flourish. That's absolutely factually true. So are you familiar with Ed Litton's work? So he's worked with Toby. So the Iron Man trial, they looked at this in ITU. So it's basically pretty safe. I think if somebody's got raging sepsis, it's probably best to back off. But if they are just an all-comer ICU patient, particularly surgical post-op patients, I think it's completely fine. That was small, but a well-conducted trial, worth a look if you're not familiar with it. So yeah, generally, yes. I think if somebody's really, really septic, then probably it's not the right time and probably isn't going to be that helpful anyway.
We remain very reluctant.
Yeah.
Because most people are in ICU for any length of time. You kind of feel are on the verge of sepsis for some reason, so that there is a ingrained nervousness that I think will take some getting over.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.